Good morning. Thank you so much for this kind invitation. I would like to present a rare complication following a routine pterygium surgery. So Ms. Tien is a 49-year-old lady who presented to the eye clinic with a grade 3 pterygium of her left eye and a grade 1 pterygium of her right eye. Her best corrected visual acuity was 6.6 in the right eye and 6.12 in the left eye. Her IOPs were within normal limit and she had a normal fundus exam. She had no comorbidities of note and she presented for the pterygium surgery and autograft. It was an uncomplicated procedure, no mitomycin C was used, and off note, there was no previous surgeries, no allergies, and no previous admissions. On day 1, her graft was in situ, she had minimal complaints of pain and discomfort, she was discharged with steroid and anti-inflammatory drops and analgesia. She was scheduled to return a month later for her post-op review. On day 30, she was seen by a colleague who noted that she had a significant amount of scleral thinning in the operated area of the left eye. A small 1 by 2 millimeters area, a deep area of thinning of her cornea lateral to the operated area was noted. The autograph was also nowhere to be seen. She was Seidel 1 and 2 negative and pooling was noted in the area of thinning. On close examination on this visit, she also had filamentous keratopathy of the right eye. The graft was not visualized and the surrounding sclera had thinned to such an extent that the blue hue of the uveal tissue could be seen. There was no scleral abscesses or a hypopion which was noticed. She had reported no pain or discomfort during the past month post-operatively, hence she did not return sooner. So she was therefore admitted. IV methylprednisolone at 250 milligrams QID was prescribed with vitamin D 1,000 units and 20 milligrams of omeprazole. Bloods, chest x-ray was done and she was booked for OT. Ms. Tien was booked for OT for a scleral patch of the area of corneal thinning, and this was done by another ophthalmologist. Clinically, on general examination, as we prepared her for theater, we noticed a large 6 by 6 centimeter lesion on her right shin. So this is a photograph of what Ms. Tien looked like on her right eye with a grade 1 pterygium. This is her left eye post-scleral patch. And finally, this is a picture of her 6 by 6 centimeter lesion on her shin. It was a non-healing right shin ulcer with dark hyperpigmented borders. The surrounding skin was cool to touch and the distal pulses was palpated and they were present. She had sustained no trauma but had reported scratched the skin so much that the skin had become excoriated. The remainder of her general clinical examination was completely normal. There was no evidence of any arthritis and no structural deformities of her fingers. At this point, I consulted with 2 other specialists in 2 other disciplines, a dermatologist for the skin biopsy and the physicians for the assessment of a suspected connective tissue disorder. This is a list of all the bloods that they asked us to do. And on a comprehensive blood workup, we found her white cell count to be completely normal of 5.86, the HB to be 9.1, which was slightly decreased. The autoimmune lab markers, the ANA, anti-nuclear antibody, and if it's more than 6, it's considered as strongly positive. In her case, it was 22. The anti-double-stranded DNA antibody was negative. Her anti-Sjogren syndrome related antigen A and anti-Sjogren syndrome type B, or your anti-Rho and anti-La respectively, were 240 and 71, and both were positive. Her anti-Smith antibody was negative. Her anti-ribosomal antibody, which is a test for lupus, which is negative, and her anti-U1 RNP was also negative. Her rheumatoid factor was 104, and the norm is between 0 and 14. Her anti-CCP, if it is more than 60, it is considered strongly positive. In her case, it was 277. The UNE was normal, her calcium magnesium phosphate was normal, and her LFTs were normal. The histology came back showing a skin biopsy with non-leukocytoclastic vasculitis with an associated leg ulceration. So just a quick discussion on pterygium. It's an elastotic degeneration of the conjunctival tissue with hyalination of your subepithelial tissue, resulting in a triangular fibrovascular outgrowth of the conjunctiva encroaching on the cornea. And there's a worldwide incidence of pterygia, which appears to be increased in areas within 36 degrees north and south of the equator, known as the pterygium belt. And most common causes include outdoor working, exposure to UV lights, hereditary factors such as your P53 oncogene, and your dry eyes. And it's very common in South Africa, especially in our black population, but it's also common in India with 1 in 10 people who seek healthcare for this particular problem. So these are a few pictures of this. An approach to scleritis, anterior and posterior. In this specific case, because we knew it was necrotizing, we honed specifically on surgically induced necrotizing scleritis. So what exactly is SINS? So it is a rare complication of ocular surgeries, namely your strabismus, your pterygiums, cataract extraction, sclera buckling procedures, and your PPVs. And it's believed to be a type 4 hypersensitivity response to scleral tissue antigens, which are altered or exposed to surgery. And it's usually seen after very uneventful ocular surgery, either at or adjacent to the surgical site. And a severe inflammation of the sclera with an aggressive and rapid course, which can lead to blindness if it's not adequately treated. So the risk factors are twofold. It can either be surgical factors or it can be patient factors. So pterygium excision is one of the most commonly implicated in surgically induced necrotizing scleritis, and this accounts for 63.4%. Also the use of adjuncts like mitomycin C and your 5-FU, extensive use of cautery during surgery, and also a lot of manipulation of the eye. Patient factors would include diabetes, your thyroid, herpes zoster, hyperuricemia, etc. The pathophysiology is autoimmunity, so there's a clinical and serological markers for connective tissue disorders which are present in at least 62% of the cases. And you have studies which have shown that IgM and IgG deposition and increased HLA-DR expression with T helper cell which are participating in this conjunctival biopsies. Underlying surgical subclinical autoimmunity is also a problem, and this is accelerated because of the surgical trauma. So the diagnosis is made on a combination of a few things: the patient's history, the clinical features and appearance, some lab markers, and even some radiological investigations in some cases. And it presents as an inflammation and a necrosis of the tissue adjacent to the surgical wound after ocular surgery, and often with a delay in presentation from the time to surgery. So the average time can be from the time of surgery to up to 9 months to up to 51 years later, which has been documented. And the symptoms can include severe, deep, boring pain occurring over several days, which awakens the patient from sleep, redness, tearing, tenderness, and pain with extraocular movement. It's very important to exclude infectious scleritis, and some of the causes include fungal, bacterial, and viral. And the differentials, how is this actually different from autoimmune necrotizing scleritis? So it's actually quite similar. However, autoimmune scleritis is bilateral, and there doesn't have to be a history of surgery. Usually middle-aged women with rheumatology disease, both eyes tend to be affected, and it can progress differently in each eye. It can occur without pain and injection, and it can lead to ocular perforation, which is known as scleromalacia perforans. This is a photo of scleromalacia perforans. Ironically, even though the name implies that it perforates, these patients hardly do. Infectious scleritis, there is a relationship between SINS and infectious scleritis, but it's not clearly understood. SINS and infectious scleritis are considered to be separate clinical entities. So Ms. Tien, her connective tissue screen revealed a positive rheumatoid factor, as well as a positivity of your anti-cyclic citrullonated peptide antibody, which has a diagnostic specificity of 96% for rheumatoid arthritis. In addition, she had elevated levels of anti-Rho and anti-La antibodies, which are indicative of Sjogren's syndrome. So she had an overlap of 2 connective tissue diseases. So methotrexate was started for her, folic acid daily except on Saturdays, and she was also managed between both rheumatology and ophthalmology. And her skin ulcer had also improved to a scar. So our take-home message for this particular patient is that it highlights the variability and the subtlety of autoimmune disease and how it can actually present as complications from eye surgery. Secondly, the attending ophthalmologist needs to be highly suspicious of an autoimmune cause if this rare condition occurs. Also, it's very important not to divorce ourselves from the fact that eyes belong to patients, and we need to look as patients as a whole. And now we are better prepared for her next surgery in the future because we know of her background of rheumatoid arthritis and Sjogren's. Also, I'd like to propose that we do ANA screening in a specific age group, female gender, especially in light of the fact that this is very common in this particular age group, especially with rheumatoid arthritis and Sjogren's syndrome. Thank you so much.
Thank you, Dr. Afroze, for such a nice case presentation. I have a question actually.
Of course, yes.
What is the relation you have found between that scleritis and with the skin disease?
What is the relation?
Relation. Because
So-
patient has developed skin disease.
Yes. So that's a loaded question, but in her case, there is an autoimmune component to the thing. So unfortunately, there is a subclinical autoimmunity. So when you disrupt the layers when you are doing operations, there's a whole lot of IgM and IgG antibodies that actually congregate at that particular area, and it's accelerated because of the trauma. That's the etiology of it.
Okay, thank you.
I have a question
Sure.
also. Don't you
Yes.
call, were the graft taken with sutures or just by glue?
Sorry?
The conjunctival graft
Yes.
by sutures?
Yes, yes,
You
of
take
course.
sutures.
Yeah.
And all sutures just melt, or what happened to the suture?
So what happened was, you're talking about the initial presentation?
Yeah, the
Yes.
autograft.
Yes, it completely melted away, and she had a very deep 1/2 lesion. So when this patient presented, we're in a very resource poor setting. It was in a government hospital. We did not think that this would ever happen. A pterygium is such a routine procedure. So we didn't take her before pictures. It was just lucky I had that one photo. I didn't have her pre-photo for the eye that was operated to show you. So I only had the photo afterward. So when the pterygium was done, it was a routine case done very quickly. And what was different about it was that the mitomycin C was not used at all, and that the autograft technique was used. So no bare sclera technique.
But what type of suture? I mean, usually this happens when you use
Oh.
6-0 or
No, it was
Vicryl sutures.
8-0
Vicryl, right?
8-0 Vicryl.
I
Yes.
think this is more common when you use BGA sutures, Vicryl. It's far less common when you use the 10-0 nylon sutures.
Okay. I
Because
did not know that.
already the Vicryl sutures is one of the causes for necrotizing scleritis. Because
Okay.
we see it sometimes when we do an eye muscle surgery, sometimes
Uh-huh.
we get the same complication just because of the suture.
Okay. Thank you so much.
Thank you.
And one thing, if you just create some graft, like sometimes you have to patch graft, you have to do the 2+ graft in such glaucoma surgery. Those patients have autoimmune disease. The tube graft,
Yes.
what is just placed over the tube,
Correct.
it doesn't actually happen there. Actually, they usually melted. So this is very much important to exclude any autoimmune disease
Yeah.
in such graft before doing some graft. It is very much important.
Would you do any bloods for that?
Yes.
So
Yes, because if patient has a history, if patient gives a history of autoimmune disease, or patient has some symptoms like joint pain or some skin diseases like that, or family history of rheumatoid arthritis, and patient has a history of raised anti-CCP, in such cases we have to do the details of it. Okay.
Yeah. Thank you so much.
Thank you. I think we were done with the session, right?
Yes.
Okay, so we can conclude the session. Thank you, everyone.